My name is Jennifer Ann Brown, and I'm a PhD candidate at the School of Public Health, University of Alberta. I'm hoping, can everyone see the screen at this point?
Yes, we can. Thanks,
Wonderful.
Jennifer.
Today, I'd like to present some key findings from a research report that I led with my supervisor, Dr. Candace Nikiforik. Based on our ScopHIA project, our objective in this webinar is to provide information and insights that resonate with public health research, practice, and policy professionals who are interested in the expanding field of impact assessment in Canada. The ScopHIA project's full title is Scoping Population Health in Impact Assessment Realist Review, identifying best practices for equity in scoping of natural resource developments and large-scale infrastructure projects. Our project was launched 18 months ago in September 2019 with funding from the Social Sciences and Humanities Council of Canada and Impact Assessment Agency of Canada as part of the Informing Best Practices in Environmental and Impact Assessments Knowledge Synthesis Grant Program. So as an important starting point for our presentation, I would like to acknowledge that the University of Alberta is located on Treaty 6 territory in Edmonton, Alberta, and that we respect, that we respect the histories, languages, and culture of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. So before we get into talking specifically about impact assessments and how public health stakeholder expertise can be brought to bear on that process, we wanted to give you all a sense of the scale and complexity of major natural resource and large-scale infrastructure projects in Canada. Canada is considered a global leader in mining projects and is home to more than half of all major multinational mining corporations. In terms of fossil fuels, we are the fourth largest exporter of natural gas and the 7th largest exporter of oil worldwide. At home in Canada, the energy and resource sector makes up about 16% of Canada's gross domestic product, or GDP, in 2017, employing over 1.5 million people. To put this in perspective, the Canadian Institute of Health Information estimates that only 11.5% of Canada's GDP was spent across the entire healthcare system in 2017, or about 5% less. From natural gas production in the Devonian shales of northeastern British Columbia to offshore petroleum drilling on the Grand Banks of Newfoundland, major projects are typically located far from larger urban centers on the traditional territories of Indigenous peoples. It follows that major natural resource and large infrastructure projects are the largest private sector employer of Indigenous peoples in Canada, and that these industries support numerous Indigenous-owned offshoot companies. Nevertheless, at the same time, land is important for livelihoods, harvesting of food, and continuation of cultural practices in these regions, meaning that environmental and other impacts have heightened ramifications for Indigenous peoples and affected communities. Given the scale and complexity of Canada's non-renewable resource extraction sector, major projects are a critical and contested site of conversations about the public interest, sustainable development, and public health in this country. Throughout their exploration, development, operation, closure, and remediation life cycles, projects can pose significant risks to regional populations, which implicates the public health concept of population health equity. Population health equity can be defined as the absence of avoidable differences in health determinants, status, and outcomes between geographic, socioeconomic, political, or demographic communities and/or subpopulations of those communities. When natural resource and large-scale infrastructure projects impact more upon Indigenous peoples and affected communities than on the rest of Canada, That is an example of a population health inequity. Both positive and negative impacts can affect population health equity in relation to projects, although negative impacts are generally of greater concern. Examples of positive impacts of projects include income and employment, educational and training opportunities, improvements to community infrastructure, and greater access to markets and services. Examples of negative impacts include exposure to pollution and loss of ecosystem services, stress on community housing, healthcare, and infrastructure, increases in infectious and chronic diseases, injuries and accidental mortality, loss of language, culture, and subsistence practices, and increased political, socioeconomic, and gender disparity in communities. Promoting a population health equity lens in relation to major projects, therefore, is critical to ensuring that the risks and benefits are equally distributed between industries and the communities in which they are located. There is a legislated process in Canada for conducting federal reviews of major projects. Industrial proponents submit their proposals to federal regulators, who then initiate a process of gathering scientific evidence, traditional knowledge, and public input. This information is used by federal regulators to decide whether and how projects should be approved to go forward and be built. In the process of conducting federal reviews, regulators can also advise proponents to modify their proposals so that they will maximize the benefits and minimize the risks of development. Prior to August 2019, the governing legislation for federal reviews, was the Canadian Environmental Assessment Act 2012, and the regulator was the Canadian Environmental Assessment Agency. 18 months ago, that legislation was replaced by the Impact Assessment Act 2019, and the regulator was renamed as the Impact Assessment Agency of Canada. Under the old legislation, regulators had a mandate to protect valued ecosystem components of the environment from significant adverse impacts of major projects. Projects were more likely to be approved as long as their proponents could demonstrate limited harm to the biophysical environment. Under the new Impact Assessment Act, decision-making will be based on whether or not industrial developments are in the public interest. This new mandate of public interest will greatly expand the scope of federal review to give full consideration to positive and negative impacts on health, social, and economic conditions, in addition to assessing environmental impacts. Although consideration of upstream and downstream determinants is familiar territory in public health, this public interest determination is new terrain for many industrial proponents. There are 5 phases in the new impact assessment legislation. First, the planning phase. The planning phase is where proponents submit their proposals to the regulator, who then consults with Indigenous peoples, affected communities, federal authorities or departments, and other jurisdictions like the provinces, territories, or Indigenous organizations to understand their potential concerns about a proposal. These concerns are communicated back to proponents, who must then revise their proposals and develop a plan to satisfactorily address those concerns through the federal review process. The planning phase lasts for a maximum of 180 days. In the impact statement phase, the proponent conducts all of the studies and carries out all of the engagement required to address the concerns raised during the planning phase. The impact statement phase lasts a maximum of 3 years. In the impact assessment phase, the Impact Assessment Agency of Canada reviews the work completed by proponents in the impact statement phase, providing recommendations whether to approve or reject the proposal, and what modifications to the proposal will be required for approval. In most cases, the impact assessment phase lasts for a maximum of 300 days. In decision-making, the Federal Minister of Environment and Climate Change and the Federal Cabinet make a final determination about the proposal. In most cases, the decision-making phase lasts 30 days. Post-decision, the proponent must carry out all of the legally binding recommendations for improving their proposals throughout the construction, operation, closure, and remediation for their projects. For the ScopHIA project, we focused our knowledge synthesis on the 180-day planning phase at the start of the federal review process. By providing increased opportunities for consultation, engagement, and input from the earliest stages, the planning phase can provide critical pathways to ensure projects make a net contribution to the public interest, sustainable development, and public health. Using a realist review methodology, we consulted the peer-reviewed and gray literatures to identify key leverage points in the planning phase, where implementation of evidence-based best practices and principles could help promote population health equity as a priority within federal impact assessment. There are a number of key activities and deliverables mandated during the planning phase of Canada's new Impact Assessment Act. These activities and deliverables could serve as leverage points for public health research, policy, and practice interventions. The initial project description is the proposal first submitted to regulators by proponents. The Federal Authority Advice Record is a request for information from federal authorities like Health Canada, the Public Health Agency of Canada, and others, to guide consultations, engagement, and research conducted by the proponent throughout the impact assessment. The summary of issues is a document compiled by regulators detailing concerns about the proposal raised by Indigenous peoples, affected communities, and other stakeholders in the planning process. The detailed project description is a revised proposal from the proponents, addressing concerns raised and documented in the summary of issues. The tailored impact statement guidelines are requirements set out by the regulators for further work from proponents based on concerns in the summary of issues, information in the detailed project description, and recommendations in the Federal Authority Advice Record. As part of the tailored impact statement guidelines, the Indigenous Engagement and Partnership Plan and Public Participation Plan detail how the proponents will be required to interact and communicate with Indigenous peoples and affected communities throughout the federal review process. Our presentation will summarize some of these key points of leverage as opportunities for research, policy, and practice interventions to implement evidence-based best practices and principles for promoting population health equity through impact assessments within Canada. For our realist review knowledge synthesis, we employed both systematic and purposive search strategies. Systematically, we searched for articles containing health and/or scoping as keyword terms between the years 2010 and to the end of 2019 in impact assessment and project appraisal and environmental impact assessment review, the most prominent specialist peer-reviewed journals. We also identified 71 additional gray literature and other documents employing purposive searching and the expert knowledge of our research team. Out of 586 documents initially retrieved, 185 were screened and retained for full data extraction based on the criteria of their relevance to the planning phase of impact assessments in Canada. Data extraction was conducted by coding all of the text within the 185 included documents using 3 broad thematic categories as a realist-informed method. These categories were devised to capture any and all pieces of evidence in the documents relevant to promoting population health equity. Our three thematic categories for data extraction were health factors as valued components, multiple value systems and ways of knowing, and building capacity for engagement and partnership. Detailed more fully in our report, evidence collected under these three themes were mapped to relevant key activities and deliverables during the planning phase. In reporting our findings in the ScopHIA report, we employed a unique alphanumeric citation format to indicate the citations that underwent full data extraction, providing a lookup table to facilitate even greater transparency. In this way, readers can easily examine the references supporting each of our individual claims and arguments. Many of the findings we present are highly condensed ideas about intervention opportunities for public health research policy and practice, which themselves could serve as the basis for additional knowledge syntheses and/or primary research. In the ScopHIA report, we identified and theorized 5 key leverage points during the planning phase. Proceeding along the 180-day timeline from A to E, these were A, preparing for impact assessment or the pre-planning phase, B, collaborating with federal authorities in public health, C, providing funding and other resources to Indigenous people for participatory processes, D, engaging to identify broad issues and concerns, and E, developing guidance for impact assessment. At each leverage point, we identified evidence-based best practices and principles under 3 key strategies for prioritizing population health equity. Notably, public health expertise will be called into play to support these strategies in various capacities. In some cases, public health practitioners will be working on the ground in partnership with Indigenous peoples and communities, conducting primary research and knowledge translation, reporting concerns back into the planning phase to set the overall direction for the federal review process. In other cases, public health researchers will be called upon to study processes, offer hypotheses, and propose solutions to address any shortcomings in the impact assessment regime. Public health policymakers will be needed to develop structures and processes so that existing healthcare system resources can effectively support planning for major projects. These interventions and more will be needed to bridge public health and impact assessment under the new mandates of Canada's Impact Assessment Act. At point A, preparing for impact assessments, one strategy for promoting population health equity is pre-planning capacity building. The Government of Canada has recognized and committed to implementing the United Nations Declaration on the Rights of Indigenous Peoples, or UNDRIP, within the preamble to the Impact Assessment Act. Public health practitioners working with Indigenous peoples and affected communities should familiarize themselves with UNDRIP as a national standard for conducting meaningful consultation during the planning phase. As part of this commitment, public health practice, research, and policy professionals can work toward ongoing capacity building at the community level by recognizing, supporting, and promoting leadership in Indigenous political, customary, and boundary organizations with a mandate for impact assessment, further strengthening participation and engagement in the planning phase. A second strategy at point A will be to employ transparent protocols for engagement with Indigenous peoples and affected communities. Public health stakeholders in research, practice, and policy roles should recognize and respect customary stewardship models and practices, appropriately engage diverse and/or marginalized subpopulations, and transparently document procedures and assumptions as protocols. The final strategy at point A in preparing for impact assessments is for proponents, regulators, and other stakeholders to engage with regional public health authorities from the earliest stages. Public health practitioners within regional health systems can support impact assessment professionals to be able to develop comprehensive and shared understandings of population health equity impacts. Public health policymakers can help develop regional structures and/or networks linking impact assessment with public health and healthcare systems. An excellent example of this kind of work can be found at Northern Health in British Columbia, where the Regional Health Authority is equipped with an Office of Health and Resource Development, which produces general knowledge products to support population health equity considerations for major projects, and which participates directly in impact assessments when needed. Many strategies at Point B, collaborating with federal authorities in public health, concern public health policy interventions. For example, federal health authorities like the Canadian Institutes of Health Research, Public Health Agency of Canada, Health Canada, and the National Collaborating Centres for Public Health can help fund impact assessment research, provide advisory assistance and guidance directly to the planning phase, and support field development by conducting knowledge translation to public health professionals. A second strategy at Point B, building on policy interventions in public health, is for federal authorities to encourage the use of what authors have called the parallel streams approach to impact assessment, employing both publicly available and community-driven data sources. Federal guidance in this area could support greater uptake of public health surveillance information in impact assessments, as well as promoting research to reflect Indigenous peoples and affected communities' population health equity priorities and concerns. A third strategy at Point B is for federal authorities to promote scientific standards to improve key areas of impact assessment practice. These could address methodological diversity in health impact assessment, provide criteria for assessing the significance of impacts, and validate means for addressing, reporting, and communicating uncertainty in impact assessments. Federal authorities are already working in these areas, and the products of that work should become widely disseminated to impact assessment professionals to support the planning phase. Point C, providing funding and resources to Indigenous peoples for participatory processes, provides another key point for intervention. Our first strategy here has to do with public health research and policy interventions. Funding requirements and procedures should be able to be meaningfully linked to broader community-driven research and development processes, facilitating the use of indicators, models, and thresholds that are meaningful to affected communities. Importantly, the second strategy at Point C recognizes that Indigenous peoples and affected communities should have a meaningful level of influence in decision-making, which will require knowledgeable, contextualized communication about population health equity implications of major projects. As part of community-driven research and development processes, meaningful influence can involve Indigenous-led assessments and knowledge translation conducted in partnership with Indigenous political, customary, and boundary organization, whose work can span multiple communities and impact assessments. One example of this kind of work was the Makivik Corporation interpreting oral testimony from Inuit elders in terminology suitable for developing impact assessment guidelines during the scoping for the proposed Great Whale hydroelectric project in Nunavik, Northern Quebec. Public health researchers and practitioners can work in partnership with these groups to support their work or to otherwise support proponents and regulators' receptivity to these knowledge products. A third strategy at Point C for public health research, policy, and practice efforts is to recognize and advocate for Indigenous peoples and affected communities as the stewards of any data or knowledge products generated, with protocols and policies in place for appropriate consideration and stewardship of Indigenous knowledge within impact assessments. As one example of such a policy, the First Nations Information Governance Committee has developed the Ownership, Control, Access, and Possession, or OCAP principles, as a framework for ensuring that community-driven knowledge remains under local control. Point D provides another key leverage point for promoting population health equity during the planning phase, as public health practitioners work with proponents, regulators, and communities in engaging to identify broad issues and concerns. During the planning phase, early engagement should strategically foster social learning across participants, situating conversations in circumstances and cultural dynamics, and sharing, interpreting, and reconsidering information in clear terms that can be translated into Indigenous languages. At the same time, engagement should facilitate improved literacy in the imagery, methodology, and epistemology of Indigenous peoples and affected communities. A second strategy in engaging to identify broad issues and concerns at point D is for public health practitioners to use multiple forums to help Indigenous peoples and affected communities in expressing and prioritizing their concerns. During early engagement, existing cultural protocols should be followed for in-person events, recognizing seasonal activities and scheduling as constraints on participation. Multiple techniques and ways of understanding the issues should be embraced, respecting risk perceptions and emotional reactions as reflections of the issues at stake. Finally, online registry information provided by regulators should be accessible and searchable for stakeholders and right holders, improving asynchronous information sharing across geographies and contexts. This is particularly true in the current pandemic situation. The final strategy at point D is for public health professionals and researchers to support the use of public health frameworks in engaging to identify broad issues and concerns. Public health frameworks provide comprehensive sets of population health equity indicators and can help to ask the right questions to support comprehensiveness of baseline profiles, predicted impacts, and mitigations. The Alaska Health Impact Assessment Program's Health Effect Categories framework provides one example of a public health framework for more comprehensively summarizing concerns in 8 areas, namely social determinants of health, accidents and injuries, exposure to potentially hazardous materials, food, nutrition, and subsistence activity, infectious diseases, water and sanitation, non-communicable and chronic diseases, and health services infrastructure and capacity. Selected in partnership with Indigenous peoples and affected communities, these frameworks can also be used to support development of the summary of issues, as well as to structure conversations about collaborations between impact assessment and public health and healthcare systems within regions. The first strategy at point E, developing guidance for impact assessment, is to promote population health equity expertise within a multidisciplinary project team, implicating public health practitioners and policymakers. In developing the tailored impact assessment guidance, Indigenous engagement and partnership plan, and public participation plan, a key strategy is for proponents to engage public health trained professionals as consultants with expertise in public engagement and assessment methodologies who employ ethical and reflective practice principles. In the long term, public health policymakers can build national expertise in this area by prioritizing population health equity as a newer impact assessment field of expertise. This level of professional development can be built through education and training across academic curriculum, institutional accreditation, and professional credentialing programs. A second strategy at point E is considering opportunities for co-development and co-management in the planning phase, since these structures will emphasize issues that are important to Indigenous peoples and affected communities. Co-development means Indigenous peoples and affected communities are engaged to conduct key activities or draft key deliverables during the impact assessment process, whether independently or in collaboration with other stakeholders, usually regulators and proponents. Co-management refers to various institutional arrangements for sharing resource development benefits with Indigenous peoples and affected communities, usually implicating structures and mechanisms coordinated with proponents. This is an important area for public health researchers who can collect evidence to evaluate co-development and co-management processes and contribute to improvements in their overall design. Public health researchers and practitioners can further support planning phase processes around the development of data and information management plans so that public health research, monitoring, and surveillance infrastructure can measure population health equity changes over the exploration, development, operation, closure, and remediation lifecycle of projects. Finally, at the end of the planning phase, the last strategy at point E in developing guidance for the impact assessment should set out how required studies will contribute to post-approval management, monitoring, and follow-up programs. This strategy mainly implicates public health researchers and policymakers during the planning phase, although public health practitioners could be involved in carrying out the work in later stages of impact assessment. Strategies should include researching and devising appropriate accountability and grievance mechanisms and setting policies for long-term access to data repositories and surveillance information across community networks. Learning from impact assessment to impact assessment is something that is set out in the legislation, but developing the structures for doing so on a national scale will require considerable work in public health. There are many opportunities for public health researchers, policymakers, and practitioners to contribute to the field of impact assessment and help advance population health equity issues in this forum. Returning back to a previous slide, we can see where each of these intervention leverage points and associated strategies layer back onto the key activities and deliverables in the planning phase for impact assessments. More information is available in our report and in a forthcoming publication to hopefully provide a map for public health researchers, practitioners, and policymakers to begin to become engaged in impact assessments as an emerging area for promoting population health equity in relation to natural resource developments and large-scale infrastructure projects in Canada. I'll now turn to Candace to provide some additional context for the importance of applied public health practice, research, and policy under Canada's new Impact Assessment Act.
Thanks so much, Jennifer Ann. So I'd like to take a moment. Jennifer Ann, would you mind moving the slide ahead for me? Thank you. I'd like to take a step back and bring us back to the big picture. We've just been through a very comprehensive understanding of the relationship between impact assessment and public health. And for those of us who work in public health, many of us are grounded in the 1988 Ottawa Charter for Health Promotion. And I really want to share with you all an opportunity to reflect on health promotion and how it might be related to environmental health and impact assessment. So health promotion is a key area of public health that involves being aware of and engaging with populations and communities well outside of the healthcare system. We often take a prevention lens in that space. And having that focus outside of the healthcare system allows us to work with communities to have increased control over improving their own health and well-being. So with this in mind, the Ottawa Charter, which you can see on your screen, sets out 5 key action areas, as well as 3 strategies, all of which are implicated in impact assessment. And that implication means that we can use these tools to improve population health and health equity with Indigenous peoples and with the affected communities facing major projects. So as you can see in the image on the slide, I know it's a bit small, but I'm hoping you can see it. And also you can Google Ottawa Charter and you could see a much more up close version of this image. But the 5 action areas in the charter are building healthy public policy, creating supportive environments for health, strengthening community action for health, developing personal skills, and reorienting health services. Underpinning these action areas are 3 fundamental health promotion strategies, and those are to enable, to mediate, and to advocate. And much of this embodies the work of us as public health folk. So when we think about our role as public health practitioners, researchers, and policymakers in Canada, we know that we're deeply embedded in the political, economic, historical, and social implications of natural resource developments, as well as large-scale infrastructure projects. In Alberta, where the ScopHIA team is based, and across Canada, we know that major projects are an inevitable part of the conversation about public interest, sustainable development, community thriving, and public health. And so when we think back to those 3 public health and health promotion strategies, which are to enable, to mediate, and advocate, then we need to, as a community, think about how we work with Indigenous peoples and infected communities to enable them to be heard in impact assessment processes that affect their health. And sometimes this looks like being allies, and sometimes this looks like raising the voices of others and stepping back as ourselves, especially if we hold a settler or colonial role. We also need to mediate between developers, regulators, and impact assessment professionals and the public health care system to ensure that planning and resources are more effectively used to support Indigenous peoples and affected communities facing these major projects. And finally, when we think about that 3rd strategy, we need to advocate to ensure that other public health professionals are aware of the population health inequities that can be associated with major projects, and to promote the work of Indigenous peoples and affected communities, organizations to be more appropriately funded and supported to lead and carry out this important work. So to reiterate a point that was made earlier, more public health education and training and grounded in appropriate knowledges and not just sort of scientific or academic privilege knowledge is needed across Canada to ensure that our professional workforce can meet the increasing need for work in this field of Canadian impact assessment for the years to come. This issue is not going away. It's in front of us every day. And I feel like we do need to pay attention to this as public health professionals. And so we hope that all of you as participants in this webinar and your networks will get involved in this promising field to address population health equity for major projects in Canada, now and in the future. And so Jennifer Ann, I will turn it over back to you.
Thanks very much, Candace, for your insights. So by providing increased opportunities for consultation, engagement, and input from the earliest stages, the planning phase can provide some critical pathways to promote population health equity through impact assessments. And this can help to ensure that projects make a net contribution to the public interest and sustainability, and indeed public health. Remember, when major projects impact differentially on Indigenous peoples and affected communities, this is an example of a population health inequity. 5 key points of leverage and associated strategies in the planning phase can enable multiple stakeholders and rights holders to implement the identified evidence-based best practices and principles through many mandated planning activities and deliverables. We encourage you to look at our report, as well as the other 12 reports produced by recipients of the Informing Best Practices in Environmental and Impact Assessments Knowledge Synthesis Grant Program, who have been working across Canada on this topic. All of these reports are available at the Social Sciences and Humanities Research Council of Canada website. So on that note, we'd like to acknowledge all of our funders in the ScopHIA project, as well as our collaborators, Melissa Gorman and Joe Vipond, our knowledge user, Jade Yahia, and our research assistants, Hejun Kim and Kelsey Schober. Thank you very much. We'd love to open the virtual floor to Tina for any questions that people may have.
Thank you very much, Jennifer and Candace. So now we'll go to questions. And while we wait for questions to come in, maybe we'll start off with a couple of questions for Jennifer and Candace. So first question, can you provide a bit more detail or examples of the types of tasks that might be undertaken by public health practitioners during the planning phase?
Absolutely. So the types of tasks that practitioners can undertake in that period should usually map onto activities laid out in relation to the planning phase deliverables, namely the initial project description, the federal authority advice record, the summary of issues, and so forth. And what tasks practitioners can undertake within each of these deliverables will depend on the roles they are playing within the impact assessment process. So public health practitioners who specialize as impact assessment consultants can act as independent contractors to stakeholders and rights holders. These independent contractors might work with proponents, for example, to draft the summary of baseline health, social, and economic conditions in the project region by summarizing publicly available population health information and ideally conducting some primary research as well as part of the initial project description. And alternately, they might work with Indigenous governments to collect and communicate population health equity information that fully represents the scope of community concerns and priorities to help contribute to the summary of issues. Public health practitioners working within regional health authorities, on the other hand, will have a different role to play. Already, regional public health authorities in areas with high levels of development have gone ahead and established dedicated offices with staff and resources dedicated to impact assessment issues. I'm thinking of the state of Alaska's HIA, or Health Impact Assessment Program, within its Department of Health and Social Services, or Northern Health's Office of Health and Resource Development. But even in regions without such high levels of development, I think practitioners in regional health authorities should be prepared for inquiries from proponents and consultants and be able to direct them to information and resources for the planning phase process. One of the key considerations for development is the new stress that can be placed on healthcare systems over the life course of developments, meaning that regional health authorities will often need to be involved in planning for increased service delivery and capacity. And what I would suggest is for regional health authorities to get into contact with the Impact Assessment Agency of Canada in their region to understand the scope and scale of developments that are in the pipeline, so to speak, to open that dialogue, which will be immensely valuable in the near future because the agency is learning how exactly to roll out this new mandate for health, social, and economic conditions consideration under the new Impact Assessment Act. So practitioners working in any role can also sign up for training with the Impact Assessment Agency of Canada by looking into training opportunities. That section of their website has level 1, 2, and 3 courses that can be taken at the introductory or more advanced level, virtually or in person, although I don't think there is anything in person at this time. But that will allow them to gain some in-depth knowledge and ask questions to the agency about opportunities to get involved.
Thanks, Jennifer. So we have a few questions coming in from the attendees. So first question, does this work identify pathways of health impacts such as air, water, soil, etc., and how do these fit into the EA process?
Yeah, absolutely. These considerations, some of which have been covered previously as valued ecosystem components, would fall under the regulatory mandate of the Impact Assessment Act, and so would be considered under the process of the planning phase by requiring proponents to conduct studies and understand the full scale of impacts to things like air, water, and soil. But under the Impact Assessment Act as well, I should say that whereas these had previously been considered valued components on that ecosystem level, they're also considered factors which can affect health, social, and economic conditions. So that provides us with an additional lens to examine potential impacts in order to understand how they would affect populations in the region. Now, in that planning phase, the process is all building towards the tailored impact statement guidelines. Those guidelines will contain requirements for proponents. Generally things like air, water, and soil, because these are established environmental impacts that have been studied for decades in this process, will be mandatory under those guidelines, generally as a matter of course. But public health professionals have an opportunity with the new expanded health, social, and economic mandate to put that lens on these impacts through the planning phase and require proponents in the tailored impact statement guidelines to address the population implications of air pollution, water pollution, soil erosion and destruction, and any of the other environmental components that the questioner might be considering as important to consider an impact assessment. So I guess what I would say is really the key is on a project to project basis, these impacts have to be incorporated in the planning phase into that tailored impact statement guidance. And that then places the obligation upon proponents to demonstrate to the Impact Assessment Agency of Canada that they've considered and identified the problems and also mitigated the harm through the planning for their project.
Thank you. Okay, next question. Was Health Canada engaged or consulted in this work? Would be curious to know how your conclusions and recommendations align with their vision.
Yeah, I think no, Health Canada was not officially or this is a bit of a delicate question because we did work with an individual who also works with Health Canada, but she, Melissa Gorman, was involved in our team as an individual affiliated with the School of Population Health, not as affiliated with Health Canada. So I just hope that's clear, and that we did draw on expertise that is informed by some of the work going on at Health Canada, but we did not consult and we do not represent Health Canada in this work. That being said, I think we have a fairly good emerging relationship with Health Canada. They're doing a lot of really excellent work in the area of things like noise pollution, guidance for specific impacts. So some of that work that perhaps the previous questioner was discussing, how do we measure these impacts? How do we conceptualize these impacts? They're able to provide guidance to proponents on how to do that work in a scientifically sound manner. Another really interesting thing that Health Canada is involved in is through the First Nations Inuit Health Branch, the collection of First Nations and Inuit health and wellness indicators. So some of that surveillance data, they're doing that work across Canada to ensure that there's appropriate surveillance information, maybe not to ensure that it's available for impact assessments, but the work is in place that can be used. So in terms of aligning with the work that they're doing, we would love to pursue additional knowledge translation. I've been involved in some of the conversations where Health Canada has been at the table, such as the Canadian Institutes of Health Research put together a Best Brains meeting last February on mental health impacts of impact assessment process and also of major projects, but also the process, where we were able to have discussions on an informal level. But in terms of the project being in any way affiliated or formally aligned with Health Canada, we are hoping to do some knowledge translation with them in the long term.
Thank you. Next question. Does the new legislation give any indication to how different information from the impact assessment will be weighted in the final approvals process? For example, are economic considerations weighted above population equity in the consideration of public health interest?
Yeah, that's actually a really tricky question. My limited knowledge as a non-lawyer, officially, this is a very sort of detailed technical thing in the legislation, but while the Impact Assessment Act lays out that health, social, and economic and environmental conditions must be evaluated through impact assessment, they're actually not legally part of the decision-making process, if that's clear. So the decision-making is based only on those aspects which are within federal jurisdiction. Because it's a federal law, the decision can only be made on the basis of federal impacts. However, the legislation does lay out that proponents must consider health, social, economic impacts. So essentially, it's a workaround for the federal legislation to be able to have proponents incorporate these modifications into their development on the basis of these areas which they must evaluate impacts on. However, at that decision-making stage, the section of the legislation that lays out what is required does not actually require all of the 20 or so areas that must be evaluated in impact assessment. It's purely on that federal jurisdiction piece. So in terms of weighting, there has been some work on this done by other recipients of the Knowledge Synthesis Grant from the Impact Assessment Agency of Canada. So I would just encourage the questioner to take a look at the Social Sciences and Humanities Research Council of Canada webpage for this particular program and scan through the titles. I'm sorry that I don't recall exactly who did that work, but I know that the public interest determination, which is what that federal decision-making piece is based on, they did some research on how to weight and determine that criteria.
Thank you. Next question. Did you review or identify solutions or strategies to address the limited capacity of regional health authorities to engage in impact assessments?
Can't say that we did. I think that would be, I don't know if Candace would like to speak on this, but I can take it. Okay. No, unfortunately, that is certainly an issue within a lot of regional health authorities. We were able to point to some of the exemplars in our view, such as, for example, Northern Health, who we talked about, the State of Alaska Health Impact Assessment Program. It's not something that we have looked at specifically, but I think it's really a question of regional health authorities learning from each other, in my opinion. One example of a really interesting regional health authority development is the Saskatoon Regional Health Authority's Public Health Observatory, where they're monitoring granular surveillance of population health status within their region and producing knowledge products, not specific to impact assessment, but that can be employed for that purpose. I think too, like being able to use national products such as the First Nations and Inuit health and wellness indicators produced by Public Health Agency of Canada and other resources from Health Canada can sort of help with that resource crunch. But unfortunately, I am speaking from my own interpretation of the evidence and not an in-depth review of that particular question.
Thank you. Next question is about, are there explicit links to the Sustainable Development Goals and integrating human rights into impact assessments, as the Danish Institute for Human Rights has developed training and resources on, both to which Canada has committed to obligations?
Yeah, again, this is not an area where we have done research, but where another team who was working in the Knowledge Synthesis Grants program has looked specifically at human rights. So I would definitely encourage the questioner to take a look at the Social Sciences and Humanities Research Council of Canada's page to see that particular report. I know that the International Impact Assessment, oh geez, the International Association for Impact Assessment has done some work looking at specifically how the Sustainable Development Goals could be leveraged into impact assessment. And from my intuition, I would say that that mapping process that we undertook, where we looked at the specific deliverables and activities within our national legislation, that could be a process that would facilitate that kind of integration. And I would love to see research teams take that up to map the Sustainable Development Goals specifically to the national legislation rather than principles in impact assessment. That would be really exciting to see. So I hope that the questioner is a public health researcher who's looking at that problem.
Thank you. Next question. Somewhat of a side issue mentioned by the questioner, but could impact the public health scope of projects. Are either of you aware of any interveners in the current Alberta Court of Appeals case on Bill C-69 IAA and constitutional scope that are intervening from a public health perspective?
I can't say that I have followed the case. I sort of forgot about it after Bill C-69 passed into legislation last August. So I'm not aware of any interveners who specifically on this case have spoken out to speak for public health. I'm not sure how. Maybe we should look into doing it too. Maybe that's something that can be my next project. But I am aware of a lot of public health associations who did intervene in the federal legislation process at Parliament. The Canadian Public Health Association produced a submission. There were some public health practitioners in Toronto who produced a submission on health impact assessment. And going through the list of interveners in that process and their submissions, you'll find that even if things are not specifically represented as public health, there are a lot of public health concerns that are more broad in the social determinants of health realm. So I wonder if maybe it's a question of sensitizing the judiciary or sensitizing the legal actors in that particular case to recognize that there are public health issues being raised within some of the other interveners' submissions.
Thanks, Jennifer. I think we're out of time for questions, but as always, I will send you a list of the questions and their email addresses, so you can reach out to them to answer their respective questions. And I want to thank you all for joining us today, and in particularly Jennifer and Candace for giving us this excellent talk and for your time to give us this talk today.
Thank you so much.
Thank you, everyone.
Stay safe.
Thanks. And also I put a link to our evaluation survey in the chat box. We would really appreciate it if you could fill it out for us so we know how you felt about this webinar. Thank you all for your time and have a great day.